encounter in day-to-day practice. So today's first we'll start with MRI sequences. So you can see in this image patient's positioning. So for shoulder joint MRI, hand should be adducted position and externally rotated in position like this, and shoulder coil you can see in this image also like this. So how to acquire the shoulder MRI images? So first they will acquire the axial image. So after that axial image, according to along the perpendicular plane or parallel to the supraspinatus muscle, they will acquire the coronal images, and perpendicular to the supraspinatus they will acquire the sagittal images like this. In this image you can see first they will acquire axial images, and on the axial image they will acquire coronal, and they will plan sagittal and coronal images. Another position for to see the labral tears and during MR arthrography, since we are having nowadays 3 Tesla MRI machine, so we won't do much MR arthrography images, but abduction and external rotation images are to see labral tear more conspicuously. So these are the imaging sequences which we do at our institute. So sagittal we do T1 weighted and PDFS images, and coronal we do PDFS and T2 weighted images, and axial we do GRE images. So you can see GRE images we do because it gives us so much information compared to PDFS axial. So in these three images you can see it gives information about glenoid labrum. You can see triangular and both anterior and posterior glenoid labrum, and it gives idea about articular cartilage. You can see its grayish signal intensity between humeral head and bony glenoid, and it gives idea about calcification. So in this second image you can see posterior triangular glenoid labrum is maintained, but anteriorly you can see this triangle is not intact. So this image is showing glenoid labral tear with capsular thickening and injury. Third image you can see that compared to second and first there is no joint space and significant cartilage thinning and significant attenuation of glenoid labrum. And in this last image, you can see there is susceptibility artifact in the subscapulary tendon at the attachment site at the lesser tuberosity, and with adjacent bursitis and soft tissue inflammation. So this is calcific peritendinitis of subscapulary tendon. So GRE image is important to give us so much information. So better to do GRE image compared to PDFS section. Then T1 sagittal and PDFS sagittal images are to see mainly bone, muscles, any lesion or any fat signal intensity. So you can see in these first and second images one fat signal intensity lesion within the infraspinatus or muscle, and it is showing fat suppression on the PDFS images. So basically to see any lesion, to see the muscle bulk. So in these images you can see there is fracture of the greater tuberosity with surrounding bone marrow edema. Here on this image it confirmed that greater tuberosity fracture, and in this image you can see there is muscle bulk loss of supraspinatus or infraspinatus. So to see the muscles, any fat signal intensity lesion or any infiltrative lesion of the bone. So bone, muscle, fat and lesion. So this is another example. You can see 52-year-old with a history of trauma. So you can see on the X-ray there is lytic destructive lesion in the mid shaft of the humerus. On T1 weighted image, you can see there is soft tissue signal intensity lesion within the humerus. So basically this is pathological fracture. So whenever you see any T1 on T1 signal intensity lesion which is almost similar to the muscle or hypointense to the muscle, means it's a hypercellular tumor. On STIR also you can see there is almost signal is almost like a muscle, so it's a hypercellular tumor. So T1 and PDFS will give us idea about cellularity also. Another similar example you can see on radiograph. This looks like zone of transitions are not wide, but according to age expansile lytic lesion with T2 and PDFS T1 hypointense or like almost isointense signal to the muscle. So in this age group we should think about multiple myeloma, lymphoma or metastasis. Then this is another example, young patient which like orthopedician was suspecting the pathological fracture in this case also. But whenever you see any case and they are suspecting pathological fracture in bone, you have to see bone marrow signal intensity and fracture margins around the fracture. So if you see in this case, there is fracture lines are very sharp, and surrounding bone marrow is not like any abnormal signal or any infiltrative. So basically, this is a traumatic fracture, not a pathological fracture. On X-ray also you can see fracture margins are very sharp, and this butterfly fragment is a classic Thrower's fracture of distal humerus. Then next two images, PDFS and coronal T2 weighted or normal PD non-FS sequence we can do. So this is mainly to see supraspinatus tendon, subacromial subdeltoid bursa, glenoid labrum and biceps labral anchor complex, and any impingement on the supraspinatus tendon by the lateral downsloping of the acromion process. So that all these things we have to see on coronal images, and you can see retraction of the supraspinatus tendon. And one more thing, whenever there is significant retraction of supraspinatus tendon, so because we won't cover on sagittal images muscle belly of the supraspinatus tendon, so to see the fatty infiltration of muscle, we can use T2 for non-FS PDFS, non-FS PD coronal images to see how much fatty infiltration of the muscle is there, because that is very important for orthopedic surgeon whenever they repair supraspinatus tendon. So this was all about MRI basic sequences which we do our institute and their importance. So next we'll discuss about joint and subacromial space. So glenohumeral joint is a ball and socket joint, and it has complex dynamic articulation between humeral head and glenoid. And glenoid is very small bone or small cavity which will like compared to humeral head, which will be deepened by the fibrocartilaginous rim or glenoid labrum, and it's the most mobile joint in the human body. That's why it's a most commonly dislocated joint also. And synovial fluid or bursa around to reduce the friction of the joint, like in other any other joint. Minimal joint fluid or minimal synovial fluid in any joint, it's a normal condition. We should not call it as like significant or mild joint effusion. That is normal to reduce the friction of the during joint movement. And bursae like subacromial, subdeltoid, or subscapularis and subcoracoid recess to reduce the friction during joint movement. So here you can see this bony glenoid is very small compared to humeral head. But to deepen the bony glenoid to for humeral head is around, you can see there is glenoid labrum, labroligamentous complex, and these are the all the rotator cuff muscles. So to provide the stability of the joint, there are two types of the stabilizer, dynamic stabilizer or passive stabilizer. So dynamic stabilizer are rotator cuff tendons, biceps and biceps pulley, deltoid, and periscapular muscles. Passive stabilizers are like we are seeing this glenoid rim, concave glenoid fossa, labrum, the glenohumeral ligament, joint capsule, and negative intra-articular pressure, which will generated by the because of the glenoid labrum and humeral head, there will be negative intra-articular pressure, which will provide passive stability to the glenohumeral joint. So you can see this glenoid is very small compared to humeral head. So this is glenohumeral joint, this is humeral head, this is bony glenoid. These both triangular component are the bony anterior and posterior glenoid labrum. This gray thing is articular cartilage. This is joint capsule. In coronal, you can see this is bony glenoid. This is humeral head. These are the rotator cuff tendon. In this, you can see this cuff tear also is there. Then in this example again, GR image, you can see there is significant joint space reduction, significant cartilage thinning, significant attenuation of glenoid labrum. This is another example. In this, you can see same findings compared to first image, but there are few loose bodies. And third image, you can see there is marked joint space reduction and subchondral bone marrow edema across the both bony glenoid and humeral head. So this was a known case of rheumatoid arthritis in young patients. So this is uh, because of rheumatoid arthritis, we are seeing the degenerative arthritis changes in early stage. Next is subacromial space. So subacromial space, you can see this normally subacromial space is 9 to 10 mm. If it's more than 12 mm is present, then we should think about like inferior subluxation of the joint. And it could be secondary to sometimes joint effusion also. And if it's less than 6 mm or 6 to less than 6 mm, that is because of supraspinatus tendon tear and superior migration of the humeral head. This is normal anatomy on the AP radiograph of the shoulder joint. So first is anatomical line, fourth is surgical line. This is greater tuberosity, lesser tuberosity, humeral head, bony glenoid, acromion process, coracoid process, acromioclavicular joint. This is clavicle. This is scapular spine. Then lateral aspect of the scapula. This is medial end. This is inferior process, and this is shaft of humerus. So this is another. This is example two of. You can see on the MR image there is complete supraspinatus tear, and there is superior migration of the humeral head and significant joint space or subacromial space reduction. This is another example. You can see there is significant subacromial space or near complete reduction of the subacromial space, and there is acetabularization of the inferior surface of the acromion. Significant degenerative arthropathy changes of the glenohumeral joint, and you can see there is significant degenerative arthropathy changes of the acromioclavicular joint also, and there is soft tissue swelling over the acromioclavicular joint. So basically, this is severe rotator cuff arthropathy with Geiser sign or Geiser phenomena. On the ultrasound, you can see there is cystic lesion or fluid signal intensity over the acromioclavicular joint, which is communicating with the AC zone. So in this, what happens because of bursal or complete cuff tear, that glenohumeral joint will communicate with the subcutaneous tissue through the acromioclavicular joint. So this is accumulation of the joint fluid in the subcutaneous tissue. This is another example. You can see here this physis is still not closed. So basically, this is young patient, and you can see here there is significant joint space reduction, but here joint space is intact or maintained. And here you can see joint diffusion with multiple loose bodies which are like almost same size as loose body, but here you can see different sizes loose bodies. So this is secondary synovial osteochondromatosis, this primary synovial osteochondromatosis. So this was all about joint and subacromial space. Next we will discuss about rotator cuff. So rotator cuff is made up of four muscles like supraspinatus, infraspinatus, teres minor, and subscapularis. So supraspinatus function is basically abduction of like from 0 to 15 degrees. Infraspinatus function is external rotation. Teres minor also does external rotation but helps in adduction also. Subscapularis will do internal rotation and adduction. And after 15 to 90 degree abduction will happen by the middle fibers of deltoid. Beyond 90 degree will be done by trapezius and serratus anterior muscle. So here you can see this is supraspinatus muscle which is arising from supraspinatus fossa, and it will attach or insert at the greater tuberosity, anterior facet of greater tuberosity. This is infraspinatus which will arise from posterior surface of the subscapularis, and it will insert at the oblique facet of the greater tuberosity of the humerus. And this is teres minor which will arise from the lateral surface of the teres scapula, and it will insert on the inferior facet of the greater tuberosity. This is subscapularis muscle which will arise from the anterior surface of the scapula, and it will insert on the lesser tuberosity of the humerus. So this is diagrammatic representation which function of the muscle. So you can see supraspinatus abduction, infra and teres minor adduction, subscapularis internal rotation, infra and teres minor external rotation. So now we'll see anatomy on the all three planes of cuff, rotator cuff. So which like in this image you can see like most anterior part is like landmark is coracoid process. So this is coracoid process. On the sagittal image you can see it's a coracoid process on anterior region, and this is uh, short head of the biceps which is attaching at the tip of the coracoid process. So next image you can see these are anterior fibers. Second image subscapularis muscle. So whenever sometime what happens on sagittal image or axial image we will not be able to see interstitial tear, but on coronal image, on this image we will be able to see. So sometime, so if any abnormal signal you are seeing within the tendon, interstitial signal, so that you can confirm on the coronal images. Next image at the level of biceps labral complex, you can see this is biceps tendon, this is biceps labral complex, and this is the anterior most part of the supraspinatus, anterior one third. So this is also have importance because sometimes interstitial this rim rand tear commonly we see in anterior one third fibers, And on sagittal image, because of the biceps tendon, which will like commonly miss on sagittal images. So always see coronal image or for anterior one third fibers of supraspinatus. Well, like, confirm on the anterior one on coronal images. This is posterior one third fibers of supraspinatus, and you can see here this is the supraspinatus. These are the infraspinatus tendon fibers, and you can see these are the merging in between that. So this is conjoint tendon fibers that we will see on sagittal images. This is posterior part. You can see it's a acromion process, and these are the infraspinatus muscle fiber. These are the teres minor fiber. These are attaching on the this oblique facet and inferior facet of the humeral head. On axial images, we are coming from above to below. This is at the level of AC joint. So you can see acromioclavicular joint. This is lateral end of clavicle. This is acromion process. Next image, you can see this is at the level of supraspinatus muscle. So this is muscle belly, and this is the tendon which is attaching here. And next is at the level of superior glenoid tubercle. So you can superior glenoid labrum level and level of coracoid process. So you can see these are the anterior and posterior aspect of the glenoid labrum. This is humeral head. This is coracoid process. Next, at the level of subscapularis tendon, you can see here, this is lesser tuberosity. This is bicipital groove. These are the infraspinatus tendon fibers. So this subscapularis is attaching at the lesser tuberosity. Here you can see these fibers are subscapularis tendon. This is anterior bony, anterior labrum, posterior labrum. So here again you can see these are lesser tuberosity. Subscapularis is attaching here. These are the fibers of teres minor or inferior one third fibers of infraspinatus. And this is anterior labrum. This is posterior labrum. In this patient, you can see there is abnormal signal in posterior bony glenoid and chondrolateral separation in the posterior aspect. And this is the inferior most aspect. You can see this is the inferior glenoid labrum part or cartilage. This is anterior both glenoid labrum. This is posterior glenoid labrum. These are the subscapularis tendon which are attaching on the lesser tuberosity. Here in the posterior aspect, you can see these are the teres minor fibers which will attach on the inferior aspect of the humeral head. So on sagittal image, you can see this is supraspinatus tendon. These are the infraspinatus. This is teres minor, and anteriorly you can see these are subscapularis tendon. So on PDFS image and T1 sagittal image, like we have discussed, to see muscle, bone, and fat, we have to see and sagittal image. And sagittal image is the only image in which we can see all the tendons at the in a single image. Otherwise, on axial and coronal, we can't see in a same plane all the four tendons. So here you can see this is subscapularis, supraspinatus, infraspinatus. Now we are coming from medial to lateral side. So you can see these are the myotendinous junction. This is infraspinatus tendon. This is teres minor and supraspinatus. So here you can see supraspinatus, infraspinatus. So this is anterior or horizontal facet. This is oblique facet to attach infra, and this is inferior facet for teres minor. And for subscapularis, this is lesser tuberosity to lesser broad. It will take like broad attachment on the lesser tuberosity. Here you can see this is biceps tendon. So this is supraspinatus tendon, infraspinatus, and in mid they will merge and form the conjoint tendon. So this is diagrammatic representation you can see here. So this subscapularis tendon, this is biceps, this is supraspinatus. In between that is conjoint tendon, infraspinatus, and teres minor tendon. So there are subscapularis has two bellies. There are multipinnate muscle is multipinnate muscle, but you should remember two bellies. So superior two-third or superior half muscle is commonly injured. So most commonly, like injury or trauma-related injury happens in superior half of the muscle because of biomechanics. So this is on coronal image. This is anatomy of supraspinatus tendon. So for supraspinatus tendon, coronal image is the best image to see the tendon tear, retraction, muscle bulk. So here the supraspinatus tendon has three parts. So you can see this is footprint attachment, and from footprint attachment 10 to 15 part is critical zone. So critical zone is most commonly injured during by the degeneration, and this is myotendinous junction. So myotendinous junction is commonly injured in trauma cases. So on this you can see this is non-FSPD. So this is footprint, this is critical zone, and this is myotendinous junction. So this is the same case, same example on greater tuberosity supraspinatus attachment, and lesser tuberosity, like we have already seen, this is subscapularis tendon which is attaching on the lesser tuberosity. Then rotator cuff tendinosis versus tear. So whenever you see abnormal or heterogeneous signal within the tendon, if it's not T2 or PDFS hypointense, so you should compare that signal within the joint fluid or joint effusion. If it's almost similar signal like joint effusion, means it's all tear. But sometimes what happens in PDFS images, like if severe tendinosis also can mimic like a joint fluid or joint effusion. So to confirm that signal, we should always confirm with on the non-FS sequence. So you can see here on non-FS and PDFS both sequences, it's almost looking like a fluid. So this basically tendon complete tear with retraction up to mid-humeral head. So whenever there is retraction, you have to tell like up to where it is. Like you should give measurement also, and like either it's a no retraction up to mid-humeral head or up to glenohumeral head, glenohumeral joint or beyond the glenohumeral joint. So according to that, they will plan the surgery. Then these are the three common tear in the supraspinatus tendon. You can see this is interstitial tear at the footprint level, which is not extending either bursal or articular surface. So in this you can see this is critical zone tear, and this is complete footprint tear with retraction of the tendon fibers. So you can see here there is residual stump at the footprint attachment. So this is basically critical zone. So critical zone is a hypovascular zone, and it's commonly injured or commonly get in tear in the degenerative cases. Next is localization of tear. So on sagittal image and coronal image. So coronal image is better to get measurement of retraction or to confirm the tear, like either it's a partial thickness or full thickness. And sagittal will give us idea about like which part of the tendon is involved, either anterior, middle, or posterior, or it's involved in conjoint, infra, or teres minor, like that. So you just should confirm on both coronal and sagittal images. And for retraction of subscapularis and teres or subscapularis and infraspinatus, we should see axial images. Then this is another importance of the subcortical or cortical cyst at the attachment of the supraspinatus tendon. So whenever you see any cortical cyst at the attachment site of the tendon, you should mention that measurement and the cyst measurement also, and mention the cyst in the impression also, because when they will if supraspinous tendon tear or any cuff tear is there, when they will fix it, that screw will not get enough bone to fix, and it will get in re-tear. So whenever you see any cyst at the site of footprint attachment of the supraspinatus or any cuff tendon, you should mention in the report. Next example you can see here, there are calcific foci in the anterior fibers of the subscapularis tendon, and you can see there is significant inflammation and bursal inflammation and soft tissue inflammation, and GRE also confirming that susceptibility artifact in the subscapularis tendon. So basically this is acute calcific peritendinitis of subscapularis tendon. So whenever you see any calcification on sagittal or AP radiograph which is going above or beyond the superior margin of the humeral head, so that is mostly it's associated with the supraspinatus, like in this case you can see. So it's a calcification at the footprint attachment of supraspinatus with bursal inflammation. So this is acute calcific peritendinitis of supraspinatus. This is another example of calcification which is extending into the bone. So that is also possible, that can extend in the bone also. So this is another example. So if you compare that first image, this image, so compared to this, in this greater tuberosity cortex is well maintained, but here you can see there is cortical break. So this is example of greater tuberosity avulsion fracture. So on X-ray you should not mistaken it as calcific tendinopathy or calcific tendinitis, because there is cortical break here. And on MR image, T1 will give us idea about, you can see that fragment which is avulged. It is not showing any calcific signal. It's showing almost like bone marrow signal of underlying humerus. So basically this is avulsion fracture of greater tuberosity. So T1 also confirms our diagnosis. This we have already discussed Weiser sign. So on MR also you can see it's same patient's MR images. You can see there is complete joint space reduction, stabilization, severe degenerative arthropathy of AC joint and large joint collection, effusion or underneath the subcutaneous plane. So this was all about rotator cuff tear and basic pathology. So now we'll discuss about rotator interval and biceps. So biceps tendon has three components: horizontal component, which is intra-articular and extra-synovial component, then biceps pulley, and then vertical component, which is in bicipital groove. Then biceps pulley, which is formed by the coracohumeral ligament, superior glenohumeral ligament, and superior subscapularis tendon fibers, and rotator interval. So basically, rotator interval is a triangular space which is situated between the subscapularis and supraspinatus tendon. So we see here. So this is the triangular component. This is a rotator interval in between the subscapularis and supraspinatus tendon. And this coracohumeral ligament, which will form a roof for biceps tendon. So in this image, we'll see one by one. So you can see in this image. So this is coracohumeral ligament. This is superior glenohumeral ligament. So whenever this biceps tendon comes out from the bicipital groove, it will take around 40 to 50 degree of turn. So that's why there are higher chances, or there will be so much pressure at the level of biceps pulley. To provide the stability at the biceps pulley, there is these tendons, ligaments, coracohumeral ligament, SGHL, and two fibers of transverse humeral ligament from subscapularis tendon. They will provide stability in the form of biceps pulley. So here you can see this is most medial part. So this is at glenoid fossa. So this is most medial part. So here you can see superior glenohumeral ligament is just medial to the biceps tendon. So here also you can see biceps tendon will arise from the superior glenoid tubercle, and SGHL also will arise from the superior glenoid tubercle just anterior to the biceps tendon. So here in this image you can see this is biceps tendon, this is SGHL, and this is coracohumeral ligament, which is forming the roof, or this is going above the level of or over the biceps and SGHL. Here you can see these are the fibers of coracohumeral ligament. Coracohumeral ligament which will arise from the lateral most part of the base of the coracoid process. So next image also you can see this is biceps tendon. SGHL is just anterior to the biceps tendon, and coracohumeral ligament is forming the roof. Here you can see clearly. This is another at the level of this biceps tendon and SGHL, they will form a sling-like structure. Now SGHL is going on the medial side, and it will form U-shaped sling on the medial side. Here it will merge with the coracohumeral ligament, and it's like little difficult on this image to differentiate coracohumeral and SGHL, but it's on the medial side of the biceps tendon. So in this image you can see nicely. So these are the fibers of coracohumeral ligament. These are the fibers of superior glenohumeral ligament, and this is biceps tendon. So they will provide the stability to the biceps tendon, which will like provide in the bicipital groove and in the joint also. So it will not medial, like it will not go on the medial side, and it will not come out of the groove also. And this is rotator interval capsule. So on this image you can see these are the subscapularis tendon, which is attaching on the lesser tuberosity. This is biceps tendon. So these are the coracohumeral ligament and few fibers from the superior subscapularis tendon fibers. So that is called it as transverse humeral ligament. But in literature there are not much like proof to like in literature they says that there is no proof of stability for the biceps tendon by transverse humeral ligament. So mainly is provided by the coracohumeral and SGHL complex, which will form the roof of this biceps tendon or the groove. And medially also that SGHL will provide stability to the biceps tendon and few fibers from subscapularis tendon. So here in this example you can see over that biceps tendon that coracohumeral and SGHL complex fibers are not there, and biceps tendon is medialized over the subscapularis tendon. So in this example, you can see that coracohumeral SGHL complex is intact, but there is injury to the subscapularis tendon and medial component of the SGHL. So that's why there is intra-articular extension or intra-articular medialization of the subscapularis tendon. So whenever you describe or whenever you see medialization, that you should mention either where either it's going over the subscapularis tendon over or intra-articular extension. This is Haber-Meyer system. This is you can read on the red source, nice article data on long head of biceps tendon injury. So like how it can extend. Sometimes only SGHL or D fibers of subscap will get injured and there will be intratendinous extension of the biceps tendon. Sometimes it can go out like I showed that case. Sometimes this also I showed. These fibers, this is little difficult to diagnose on MR. This is like we have discussed, this is anterior rotator interval, this space between the subscapularis and supraspinatus tendon. So whenever you see, basically component of the rotator interval is a fat. So whenever you see fat and coracohumeral ligament is normal, rotator interval is normal on MR. But if you see compared to these two images, there is no fat on the anterior rotator interval or rotator interval. There is complete effacement of fat pad. There is significant fibrosis in anterior rotator interval and significant thickening of coracohumeral ligament. So basically, this is a known case of or confirmed case of adhesive capsulitis. So in this another example, you can see thickening of coracohumeral ligament and effacement of fat pad of rotator interval and fibrosis in the anterior rotator interval. So and thickening of the capsule. So this is also a case of adhesive capsulitis. So this was all about biceps pulley, rotator interval and biceps. So now we'll discuss about glenoid labrum. So glenoid labrum is divided into six quadrants on the sagittal images. This is superior, inferior, anterior inferior, posterior superior, and posterior inferior. So how you will divide? So just remember, coracoid process is always anteriorly. Either it's a right, left shoulder. Coracoid process will be anteriorly. So you can divide it into six quadrants, and here at coracoid will be at 1 o'clock position. So according to that, here it will be 12 and 3 in anterior, 12, 3, 6, 9. So whenever you describe any labral tear, you should give quadrant and o'clock position. So it will be easy for arthroscopic surgeon to see on scopy. So on anatomy, axial anatomy, you can see on glenoid labrum. So basically this triangular part is glenoid labrum. T2 labrum will be most of the time it will be hypointense on the all sequences. So you can see here T2, this is non-FSPD sequence. We can see nice T2 hypointense triangular labrum. This gray signal is articular cartilage, and where those both are merging, it's a chondrolabral junction. Anteriorly, this will continue with the capsuloligamentous complex. So we'll start from above. So you can see here, this is articular cartilage. This is anterior, this is posterior glenoid labrum. Here you can see this is anterior glenoid labrum, this is posterior glenoid labrum, articular cartilage, this is chondrolabral junction, and this is labroligamentous complex. Next, you can see this triangular part is anterior glenoid labrum. This is posterior glenoid labrum, articular cartilage. This is labroligament, chondrolabral junction, and this is labroligamentous complex. This is biceps tendon, lesser tuberosity. At lower down, you can see this triangular part is labrum. Posteriorly, also glenoid labrum. This is articular cartilage. So this was basic anatomy of glenoid labrum and how to divide into o'clock position and quadrants. So just remember coracoid at 1 o'clock position and divide into quadrants, six quadrants and o'clock. Then tear. So superior labral tear. So you can see these two coronal images. So on PDFS image, you can see this triangular T2 or PDFS hypointense signal is intact. But here if you see that hyperintense signal is arising from the medial side and extending into the biceps labral complex. But if you see this third image, this signal intensity is very smooth and it's extending towards the glenoid. So whenever any hyperintense signal which is extending towards the biceps tendon anchor complex, so that is basically tear. And if it's going towards the glenoid, then it's sublabral recess or superior sublabral sulcus. So superior sublabral sulcus is commonly seen at the 11 to 1 o'clock position. If any tear, if you are seeing any tear in the antero superior from 11 to 3 o'clock position, before calling it as tear, you should think twice because most of the anatomical variants are situated in the anterosuperior quadrant. Like a superior labral sulcus is seen 11 to 1 o'clock position. So whenever any tear is extending beyond the 3 o'clock position or any signal intensity which is extending or we are seeing below the 3 o'clock position also, so then it's most likely it's a normal, not a normal anatomical variant. And if it's extending between 1 to 11 to 1 o'clock, and very margins are smooth and extending towards the glenoid, then mostly it's an anatomical variant. So like these three examples we will see. So first is labral tear, second is Buford complex, and third is sublabral foramen. So how to differentiate and how to identify? So if you see here, so this anterior labrum is margins are fuzzy, and this labral tear also there is margins are irregular, and there is joint fluid adjacent that, and capsule is also thickened. Second, if you see anteriorly there is no bony, oh sorry, there is no labrum, but MGHL is significantly thickened, but it can mimic with the labral tear. So we should confirm on the sagittal. So if you see there is significant thickening of the middle glenohumeral ligament because it's obliquely oriented, and this is the part from as anterior to the SGHL it will arise and it will go like this underneath the subscapularis tendon. So confirm on sagittal, and you can see there is significant attenuation of the anterior labrum and thickened MGHL. So you should not call it as tear. And third is sublabral foramen. Sublabral foramen is situated between the 1 to 3 o'clock position. So if you compare first and third image, these margins of the sublabral foramen will always be smooth, and labrum signal also will be intact, and adjacent there won't be any fluid or capsule injury. So this is another example of labral tear. You can see this is a recurrent shoulder dislocation case. In that you can see from 1 o'clock position anterior glenoid labrum is not there. So there is anterior glenoid labrum tear, and there is capsular tear, and adjacent periosteum also it's stripped off or elevated. Here you can see I'm not discussing today those eponyms of labral tear like alpsa, polpsa, perthes and all, because there is no requirement of giving these type of names in the report. Just you can describe the findings and leave it. So this was all about glenoid labrum and tear. Next we'll discuss about joint capsule and glenohumeral ligament. So these are like will not be able to differentiate all those ligament from the joint capsule because they all are merged and they will form capsuloligamentous complex. So you can see these are the superior glenohumeral ligament, this is middle glenohumeral ligament, this is inferior glenohumeral ligament, and this is posterior joint capsule. So here in these images, so whenever there is joint effusion or whenever we do MR arthrogram, that time we will be able to see all those ligaments and joint capsule nicely. So at the level of biceps tendon, you can see this is superior glenohumeral ligament, which will arise just anterior to the biceps tendon, and this you can see obliquely oriented middle glenohumeral ligament, which we have seen already, just underneath the subscapularis tendon. You can see here also. And on this sagittal image, you can see these are the anterior joint capsule and anterior band of the inferior glenohumeral ligament. These are the posterior band of inferior glenohumeral ligament, and this is axillary pouch. So in this image, you can see this is a middle glenohumeral ligament. Here, that is complex coracohumeral biceps tendon, superior glenohumeral ligament. This is anterior joint capsule. This is posterior joint capsule. These are the fibers of inferior glenohumeral ligament, and this axillary pouch and joint capsule. This is example, you can see the inferior glenohumeral ligament at the glenoid attachment is high grade injury. On the sagittal also you can see there is significant or high grade injury of the anterior band of inferior glenohumeral ligament, superior glenohumeral ligament, middle glenohumeral ligament, all ligaments or capsule is injured. So you can directly mention high grade injury of anterior-inferior capsular ligament complex. So this was all about joint capsule and ligaments, and now bursa and neurovascular bundle around shoulder joint. So there are three bursa and recess, common bursa and recess around shoulder joint. So this is subacromial subdeltoid bursa. This is subscapularis recess, this which will form U-shaped sling over the subscapularis tendon, which will communicate with the glenohumeral joint. So whenever we see glenohumeral joint effusion, subscapularis recess also will get distension. So next is subcoracoid bursa, which will not communicate with the glenohumeral joint. And subacromial subdeltoid bursa also will not communicate with the glenohumeral joint if there is no cup tear. If there is cup tear, it can communicate with the glenohumeral joint. So these are the two examples of the bursitis. So whenever you see bursal fluid, bursal inflammation, which is extending beyond the level of head and neck junction of humerus. So you can see in this example, this bursal fluid or inflammation is extending beyond the head and neck junction, and that fluid is dirty. You can see dirty signal intensity within the joint effusion. And if you see in this case that joint effusion is not bursal fluid is not extending beyond the head and neck junction, and that fluid is clear compared to this case, and there is synovial proliferation. So basically, this is chronic phenomena or chronic synovial bursitis, and this is acute bursitis. These are the three common site where nerve get compressed. So this is suprascapular notch, this is spinoglenoid notch, this is quadrangular space. So whenever you see any neurodenervation related edema in supraspinatus and infraspinatus both, you should see this area very carefully. Whenever you see only infraspinatus muscle neurodenervation edema, spinoglenoid notch, you should see very carefully. Sometime what happen, there will be posterior labral tear and large paralabral cyst which will compress this nerve at this level. And whenever you are seeing any neurodenervation edema in axillary nerve, teres minor and deltoid muscle, that time you should see quadrangular space because there will be axillary nerve compression. Here, suprascapular nerve compression in the suprascapular notch and spinoglenoid notch. So in this example case, you can see nerve denervation edema of supraspinatus and infraspinatus, that is secondary to compression of the suprascapular nerve in the suprascapular notch. Here you can see compression due to paralabral cyst in the spinoglenoid notch, and you can see edema in the infraspinatus muscle. So next is bones. So we are having 10-15 minutes. I'll discuss about anterior shoulder instability quickly. So, so on bones. So first you should remember at the level whenever you see or whenever you see any rotator anterior shoulder instability case, always see above the level of coracoid process. So if you see here, there is flattening or this depression of the posterior superior aspect of the humeral head, but I'm at the just below that level of flattening of the humeral head, but you are seeing the depression of the humeral head. So this is normal phenomena. So you should not mistaken this it as a Hill-Sachs lesion. Hill-Sachs lesion you should see always above the level of coracoid process, or if you are scrolling the MRI or MRI, it should be between the first three slices of the humeral head from above. So if you see here, so here you can see there is depression. This is above the level of coracoid process, and we can see on sagittal also we can see this is flattening and bone marrow edema and contusions are there. So basically this is Hill-Sachs lesion. So next image you can see here still, but we are seeing this flattening, but this is below the level of coracoid process. So basically this you should not mistaken it as Hill-Sachs lesion. This is a normal depression of the humeral head. So, and next is bony glenoid. So always see this is this anterior bony bump of the bony glenoid. So whenever you see any case or any young patient whoever is giving history of shoulder instability, always see bony glenoid on the T1 weighted image. If you are not seeing this bony bump on the anterior surface and seeing the flattening, should think of bone loss of the bony glenoid. So extreme of glenohumeral ligament in IGHL will provide stability during extreme motion of the bony joint. So how to calculate bone loss? So you all people can go through this article, bipolar bone loss Hill-Sachs lesion. So this we will see. So basically whenever we do during the movement of the glenohumeral joint, almost 83% of the bony glenoid only will be articulating with the humeral head. So that's why whenever we calculate glenoid bone loss, we will calculate 83% because 83% of the bony glenoid only will be articulating with the humerus. With complete 100% of bony glenoid will not articulate with the humeral head. So according to that, we should see like how much is the glenoid tract. So basically, glenoid tract is the 83% of the humerus head. So if its Hill-Sachs index is the defect in the humerus head, if it's more than that glenoid tract, then it's a off track or engaging lesion, or if it's less than that, it's a on track. So how to calculate bone loss? So at the level of coracoid process, like we discussed, here you can see we should measure from the medial part, most medial part or at the site of infraspinatus attachment. So that will be Hill-Sachs index. Humeral bone loss, you should draw a circle and you should draw a freehand measurement of the defect. So that will be our uh, humeral area, bone loss area. Then you should measure the how much is the circumference of the bone loss is there, and you can mention depth of the Hill-Sachs defect also. Then for bony glenoid, that recon images should be parallel to the inferior two-third surface of the bony glenoid and parallel to the axial images or axial surface. So whenever you are most outside part of the bony glenoid, you should measure a circle. So your circle should fit in the posterior and inferior most part of the bony glenoid. So here if you see that circle should fit in the posterior and inferior most part of the bony glenoid. So this part will be the bony glenoid bone loss. So area of the circle divided by the this area divided by the area of this circle. So you can draw freehand in this. So that will be your glenoid bone loss. And if you want to see the glenoid tract, so you have to draw a complete diameter of the circle and then the bony glenoid defect. So you have to take 83% of this diameter, because we have seen only 83% of the bony glenoid will be articulating with the humeral head during movement of the glenohumeral joint, and this will be out of that we should subtract that bone loss. So out of that we'll get whatever we'll get, that will be glenoid tract. So if this glenoid tract is less than Hill-Sachs index, then it's a off track lesion and engaging, and if it's more, then it's a on track lesion. So these are the few examples. You can see there is very small Hill-Sachs index and very small bony defect of glenoid. So there is, both are very small. So this is on track lesion. Then if you see here that Hill-Sachs index is quite big, and glenoid defect is very small. So this is off track or engaging lesion. If you see here, Hill-Sachs index very small, but glenoid tract is big. But glenoid tract is big compared to Hill-Sachs index, so it's a on track lesion. And again you can see here, glenoid defect is quite big, but Hill-Sachs index is also big. So this is a off track lesion. So basically you just remember humeral head bone loss or humeral head defect, engaging and non-engaging, we are seeing to confirm that remplissage procedure should be done or not. And glenoid defect we are seeing to see Latarjet procedure should be done or not. So like this we should see bipolar bone loss. So engaging, non-engaging will be decided by Hill-Sachs index, and glenoid bone loss will be due this, and glenoid bone loss we can decide through the circle method. So whenever glenoid bone loss is more than 15%, they will go with the glenoid bone reconstruction or Latarjet procedure. And if it's engaging or non-engaging, if it's engaging, then they have to fill that humeral head defect also. So that is called as remplissage procedure. Same thing if its glenoid bone loss is less than 15%, and if it's non-engaging, then they will just repair that anterior Bankart or soft tissue repair. And if it's engaging, then they will do arthroscopically repair with remplissage procedure, because it's engaging. So just remember, Hill-Sachs index is mainly to see engaging and non-engaging, and bipolar and glenoid bone loss to decide it's like glenoid bone loss to decide anterior glenoid bone reconstruction should be done or not. So it's a 15 or more than 15%. So this is an example. You can see there is large glenoid bone loss. It's definitely more than 15%, and it's, so if you see here, this coracoid process is normal, but in this you can see that they have cut it from here and they have fixed it here. So this is called it as Latarjet procedure. They will fix coracoid process in anterior and inferior bony glenoid. So here you can see they have filled that infraspinatus tendon within that defect of Hill-Sachs. So this is called it as remplissage procedure. So how should your report look like in recurrent shoulder dislocation cases? So you can see here. So we do mention over that Hill-Sachs lesion. So which will like how much it's occupying, or how much is the surface area or bone loss, then span of the circumference and humeral index or Hill-Sachs index. Then Bankart lesion, for that we have to mention labral tear. Either it's involving that biceps labral complex or not. And then we have to divide that bony Bankart. If bony defect is there, how much is the glenoid bone loss is there? Then we have to give glenoid type, because on the basis of glenoid humeral index or Hill-Sachs index and glenoid tract will describe or confirm either it's engaging or non-engaging, and on the basis of glenoid bone loss, we will decide Latarjet procedure or bone reconstruction of anterior bone glenoid should be done or not. Then your normal anatomical variant. So like we have discussed, this is sublabral recess. And whenever you are seeing abnormal heterogeneous bone marrow in young patient with interspersed area of fatty marrow signal intensity, so you should not call it as bone marrow infiltrative lesion. You can, if interspersed area of bone marrow signal intensity is there, you can do another contralateral humerus images also, because sometimes bone marrow conversion or reconversion can mimic some infiltrative lesion. Then these are the normal humeral cyst at the posterior superior aspect of the humeral head. So this you should not call it as some abnormal cortical cyst. This is a normal variant. So these are the two normal fusions. So you can see here. So whenever you see any osteolytic or lucent lesion at the greater tuberosity area, should not tell it as lesion, or you should not biopsy. This is do not touch lesion. It's a pseudo lesion because of excessive cancellous bone or due to traction, there will be osteoporosis in that region. So that is called it as, because of that, it's a called it as pseudocyst of the humerus. So this you should not biopsy. This is another example of pseudocyst of humerus. This is because of internal rotation or posterior dislocation of humerus. So that call it as light bulb sign also. So this is also a do not touch lesion. You should not biopsy, or you should not give it as some cyst or cystic lesion. Then this is another example of normal anatomical variant. So whenever you are seeing any significant cortical thickening with intracortical lucency in the proximal humeral shaft. So this is normal anatomical variant. This is not some pathological lesion. So this is pseudotumor deltoideus, where deltoid muscle insert. So whenever you are seeing cortical thickening with intracortical lucency, so this is normal anatomical variant. This also should not mistaken it as some round blue cell tumor or acute osteomyelitis or osteoblast. Yeah, this is all about. Thank you.
That was a great session, Dr. Vipender. You very efficiently covered almost the entire spectrum of the common shoulder pathologies that we encounter on a daily basis. There are some questions from the attendees which I
Yeah.
would like you to take. So the first question is how to differentiate the pseudo lesion which you have just showed from the simple cyst.
Yeah, for if it's like clinically really suspecting, then we have to go, because on CT also we'll see the same signal intensity, so we can go ahead with MRI. But we should not biopsy directly on the basis of X-ray or CT.
Okay, so the other question is how to differentiate between sublabral foramen and sublabral recess.
Sublabral foramen and recess. So basically, recess will be at the 11 to 1 o'clock position, and foramen will be usually at 1 to 3 o'clock position.
Okay. Uh,
If it's
Another
extending
question is
beyond the 3 o'clock position, then mostly it's not a normal variant. And if it's extending posterior to the biceps labral complex junction, then also it's not a normal variant, most likely.
okay. Another question is that is there any objective criteria for the coracohumeral ligament thickening?
Mm. That I'm not sure actually. But
I would like
whenever you are seeing any effacement of the rotator interval fat, then you can call it as like anterior rotator synovitis. So I feel compared to PDFS image, non-FS images are more important, because that will give us good idea about fibrosis in the rotator interval. So I feel effacement of fat or fibrosis in the interval is more compared to coracohumeral ligament thickening for confirmation in rotator interval synovitis.
yes, very well explained that it is uh, mostly eyeballing, but there are some authors which say that 2 to 4 mm is the normal coracohumeral ligament thickness, and more than 4 mm, there are some articles which say that more than 4 mm should be called coracohumeral thickness.
But
So
again, that uh,
the next question is what is a Hagel lesion and its extent?
sorry.
What is a Hagel lesion?
Uh-huh. Hagel lesion is basically humeral avulsion of glenohumeral ligament, inferior glenohumeral ligament band. So if you see 1 minute, I'll show you. On some images. If you see in this image, these are the bands of the these are the inferior anterior-inferior glenohumeral ligament or inferior glenohumeral ligament. So there will be attachment of the humeral attachment of the glenohumeral ligament here, and here will be glenoid attachment of the inferior glenohumeral ligament. So whenever there is avulsion or any injury from the humeral attachment, we will call it as humeral avulsion of glenohumeral ligament. Basically, it's a inferior glenohumeral ligament injury. Either it's like from which part, it's a Hagel and Gagel. So if it's like glenoid attachment injury, I showed one case, right? Uh, so basically, whenever this inferior, this case, you can see here. So inferior attachment of the inferior glenohumeral ligament attachment at glenoid, basically this is Gagel or if there is not bone avulsion, you just give it as high grade injury at the glenoid attachment. If there is any bone chip or bone fragment, if it's coming, then you can call it as avulsion fracture or Hagel, humeral avulsion from the glenoid. So these are the bands where they are attaching at the humerus. So if you are seeing any bone fragment or bony chip from here at this site, then you can call it as Hagel or humeral avulsion of glenohumeral ligament.
Another participant has asked that can we comment on marrow infiltration versus fat replacement without comparison with the contralateral limb?
It's difficult. Better to compare with contralateral.
The next
So
question
whenever
is,
you are seeing this interspersed area of fat within the heterogeneous marrow, means mostly it's a benign pathology, but better to confirm it with contralateral, contralateral numbers.
the next question is, what is a low-lying acromion?
This lateral low line acromion or just
Low
downsloping.
lying, I think
So
he must be asking about the downsloping.
yeah. So basically, whenever you see coronal image, or better to see on the radiographs. So whenever you are seeing subacromial space reduction or any spur which is impinging on that this on the coronal images, if you are seeing that space is reduced and if it's indenting on the supraspinatus tendon, so that is more important. Like whenever you see, sometimes can be anterior or lateral downsloping also. So whenever you are seeing any downsloping with effacement of fat pad and if it's indenting on that, and if you are seeing any bursitis in that region, so that time it's important to see any lateral downsloping. Exact criteria, I'm not sure, like where what he wants to ask. I'm not sure.
Okay, the next question is, what is rotator cable?
Okay. So rotator cable is basically, that is also not much clinical importance of rotator cable. So that will provide the stability to the both supraspinatus and infraspinatus tendon. These on sagittal images, you can see all those supraspinatus and infraspinatus tendon. If you see here, this in hypointense band, this is basically rotator cable which will provide those both supraspinatus and infraspinatus tendon. So whenever both supra and infra tendon injury is there, so it will like not allow them to retract more, but in like in degeneration, that this rotator cable also will get degeneration and there are like significant retraction in this tendon. But there is not much clinical significance of rotator cable.
Okay, one of the participants has asked to explain again the Hill-Sachs index and the Hill-Sachs defect.
Again, this will take so much time. Should I describe?
Okay, we can skip this question. Please show the shoulder positioning and imaging protocol once again.
Yeah. Uh, Shoulder positioning should be like this: external rotation, adduction, uh, axial. You can see at first they will acquire axial images. On the basis of axial, they will acquire coronal and sagittal images. Then at our institute, we do these. 5 sequences, T1 sagittal, PDFS sagittal, coronal PDFS, coronal T2 or non-FSPD, and axial GRE cases.
Okay, I think this is it for today.
Thank you so much,
It was
Malik.
great having you with